So let's just take an example about Parkinson's disease. Why not? This is the disease we know the best. It is really an emblematic disease because it has, although it looks more complicated than it is at the first glance, but really this is emblematic because you have one disease which is due to the degeneration of one place, which is the substantia nigra. It's called nigra because it's black. Inside of it, you have cells which are producing dopamine, which is the most important neurotransmitter among those we have. And this, in those circumstances, neurodegenerative disease may kill those cells, and you see that the brain stem becomes white, and then the dopamine has disappeared, which induces what is called the symptomatic Parkinsonian triad, meaning that it has three symptoms mostly. Tremor, which is the most visible but not the most disabling symptoms, the most disabling being the two others, akinesia or bradykinesia in English, and the rigidity, this making your mobility extremely difficult to achieve, just simple as that. It's not so frequent, it's not so rare. We don't know exactly how it happens, although there are tons of hypotheses. But globally, currently, we consider that Parkinson's disease and related disorders come from the combination of an environmental toxic, which acts on a genetically predisposed background. That's the current global equation. And then it's not lethal, but it's extremely disabling. And then what can we do to help those people? Because it happens in middle age, and then it kills your social life, your family life, your friendly life, more than if it were really a lethal disease. So we have a few therapeutic options. One is medication, which is a replacement therapy. This is also why the disease is emblematic, because you miss one neurotransmitter, which is finally a kind of hormone. And if you give it back, then globally, you solve the problem. And this is what happens, at least for some time. The problem is that dopamine cannot cross the brain barrier by itself. It has to be made from a precursor, which is levodopa, which allowed Arvid Carlson to get the Nobel Prize in 2000. And this medication, if you take it, when it goes to the brain, it's decarboxylated, as you can see it, and then it leads to dopamine, which is what you want. The effect is immediate, spectacular. It's called a miracle drug. It has been a revolution. You may have seen the movie Awakening and a lot of other instances like this where you can see that this is wonderful, so simple, and you give a treatment and you have resolution of the disease apparently, and then this is why it's wonderful. The problem is that there is always the other side of the medal, and after a few years, 5 to 7, you see the contrary of this disease, which is hypo movement, which is transformed in hyper movement, and those patients start having absolutely involuntary, extremely ample movement, which are called levodopa-induced dyskinesias. And if you see that, it's sometimes impressive. I was having a dinner with one of my patients in a restaurant, and she took more pills than needed just to make sure she would not be frozen, akinetic, and then she became hyperkinetic. And seeing her eating a spoon of rice, it's something extremely interesting. At least the whole population of the restaurant was very interested in seeing this. The patient prefer that than being totally, they feel buried in sand when they have the akinesia, while at this time, at least, even if the movements are extremely jerky, you can, at a time, be in front of the key you wanted to hit on the keyboard. The alternative for that, because of the dyskinesias, is neurosurgery. So it's a very old disease, very old surgery, very old treatment. He was born in 42, which is my age, so you see how old it is. And then it was essentially based on empirical observations by a neurosurgeon. They are stupid, but not that stupid, so they can observe sometimes a good thing, and particularly when they make errors, they can take advantage of the errors. So it came well known that if you destroy with intention or without some place in the brain, it may make a change, and particularly it may make a change in diseases. And if you make a lesion in the thalamus, which is about here, so the thalamus and the pallidum, which is about less than 10 millimeters far away. So if you make a lesion here, you have an effect. The problem is if it is not in the right place, you don't have the effect you wanted. And as a consequence, you had effects that you did not want, which are most of the time complications. For instance, here, the lesion is too far front. It should be here. It's not the patient I operated myself. And then you don't relieve the tremor, you would here, and you have complication which might be a paralysis because you encroach the pyramidal tract. So those complications also are not desired, and the question is, do we have something else to treat those patients? And then the solution, you find them in research, of course. It's not here that you would disagree with me. And the essential goal of these researchers was to bring dopamine where it is needed, which is finally at the termination of the nigrostriatal fibers, which are in the striatum. And this is here globally where you should put or you want to have dopamine delivered. So it can be done by neural graft. I passed on that. It is a failure, let's say a global failure. There is still some hopes in stem cells, but you know, it looks like the buoy you have when your boat sank. You know you are going to die. You find a piece of wood and you say, oh God, I will try this one, maybe this one. So the other way is gene therapy. We've heard about it. This might be one of the hopes currently, and particularly in Créteil, Stéphane Palfi is doing quite interesting work with patients who are showing some improvement when they are transfected with the three main genes of dopamine synthesis and using an antivirus technique. And so far, let's see what happens in a few years, but it might be still a hope. The other way is more brutal, more simple. It's just inject drug delivery with using pumps, etc. And this has been working for a while in England. I saw the patients, I saw the videos, it was impressive. Then it came to the States where they did a large clinical trial multi-center, which is the best way to kill a good idea, and actually they killed it. So we have to do it again one day when we have time. So the other way is just to wait for luck, or in science you call it serendipity, and this is what happened to me. And in 1987 I was doing a thalamotomy for essential tremor. Essential tremor is like, looks like Parkinson, it's not Parkinson. It has no medical or chemical correlate. We don't know what is exactly the mechanism, but it is extremely disabling. It's a very ample tremor. It does not stop, and on the contrary, it increases when you do something. So if you want to take something, then you cannot grab it. And it works beautifully if you make a lesion in the thalamus. So this is what I was going to do. And as I said, you better be in the right place. And to be in the right place, you have to check around. To check what? To check you are not in the wrong place. And the best way to do it is to stimulate electrically, which normally enhances the activity of the place you are. If you are too posterior, then you are in the sensory place, and the patient say, oh, I feel some tingling in the hand and in the mouth. If you are too lateral, you are in the pyramidal tract, which is motricity, and then you get motion like this. So you know that behind you might have, it will become more interesting. you may have a loss of sensitivity and pain, and then you may have also paresis if you are too lateral. So I was doing this, as everybody did, but I'm a little bit obsessive compulsive, so just stimulating 30 hertz was boring. So I tried 1 hertz, 5 hertz, 10 hertz, 30 hertz. I could not go higher than 100 hertz because at that time the stimulator was blocked at 100 hertz. And what I saw, this is what you see, that the voltage to do something, and particularly to decrease the tremor, which was not what I wanted to do, happens at about 100 hertz. And at 100 hertz, what I saw was that the tremor of my patient, it's done under local anesthesia. Oof, can I multiply by 3? So this was, we stopped the tremor. I stopped the stimulation, tremor recurred, I started stimulation, tremor disappeared. We did that in 5 patients. We didn't have clean ethical committees at that time, fortunately, so we could pass to clinical trial very quickly. And this has become, since at that time, the best choice for surgery all around the world, and several 100,000 people have been operated. So we thought at the moment, aha, this might be the solution. This is a serendipity. This might be the high-frequency stimulation, the solution. It's now an established surgery. You just put your electrodes into the place you want. You connect them to stimulators which are under the skin, which existed at the time, which is not very different from cardiac pacemakers. And then there are several secrets for a success story. The first is frequency. At low frequency, up to 50 hertz, you excite, so we don't obtain anything interesting for us. On the contrary, at 100 or 130 hertz, we have a total inhibition, and you will see that tremor stops, and you stop stimulation, tremor recurs. So the other secret story is secret for a success story is like in Treasure Island. You need a map and the coordinates on the map. And the map, that's the brain, the coordinates are where you have to go. So you can use different methods, and particularly microelectrode recording and stimulation. Micro-recording gives you patterns which are very specific of the different structures where you are, subthalamic nucleus, substantia nigra reticulata. And on the contrary, if you stimulate, I hope it will work. We had difficulties to start it. Okay. Then, yeah, you see the patient say stop, and then we turn on the stimulation, the tremor of the patient stops on the right hand, and then if we stop stimulation again, then the tremor recurs. So then we went to application of that to Parkinson's disease. We have several targets. This one is the thalamus. You've seen what happens. This is where we discovered that, and the tremor. The patient here cannot write, cannot do anything with right hand. That's a young patient. And Pierre Pollack, who was my colleague in neurology, gives him a magnet. It activates stimulation, and then the tremor stops. If we put an electrode in another place, which is in the pallidum, you see here patients having the so-called levodopa-induced dyskinesias. It's not exactly a ballerina's dancer, but I could not bring one. And you turn on the stimulator, you see the disappearance of these dyskinesias. But it works only on dyskinesias. It's not very efficient on the other symptoms. The queen of the target, the subthalamic nucleus, which was worked out by Manon Delong, who shared with me the Lasker Prize, as you can see, a wonderful target. This patient is without medication, and of course, before surgery. You see, he cannot walk, he's tiptoeing because he doesn't have DOPA. And then 3 months after surgery, without medication, just with the stimulators on, he does exactly whatever the neurologist wants. He can stand up, he will walk, he will even turn to make a waltz before the Vienna meeting of movement disorder. So this is what we could use. You see 3 different targets and the benefits on all symptoms. There is a situation which is called freezing of gait, where patients are suddenly stuck to the floor and they fall. And you see here this patient who will be in this situation. We have made the environment complicated, which makes him stressed, and then symptoms increase, and you will see that he will fall. And in this next segment of the video, you will see that we have put 2 electrodes into the posterior part of the brainstem, so-called the pedunculopontine nucleus, and you see that the gait is improved. But the difference between those 3 videos and this one is that this group of electrodes is stimulated at 25 Hertz, which is not inhibitory. On the contrary, it's excitatory, because the pedunculopontine is going down with the disease, and then you have to excite it. So it shows the importance of these. Here we have a young boy with a mutation of DY31 gene. This leads to this type of involuntary movement also of the dystonia, and this is extremely disabling, of course. And we have put 2 electrodes into the pallidum, and this is what happens 3 months later. He is just going back to bike, and he was invited by the Breakthrough this year to give me the prize, which was a very emotional moment. We can go in another place, which is the subthalamic nucleus. And here you see a little in the subthalamic nucleus. The same I showed you for the Parkinson, and you see that she's very well improved. And even we can put electrode in the 2 targets to enhance the benefits. So then we go to other indication. I will just shuffle the book to the press book to show you what we can do with this. And this is a cluster headache. Cluster headache is a kind of migraine, vascular migraine, extremely painful. And this patient has not won a combat against Muhammad Ali. He just has a fit of cluster headache. And if you put an electrode in some place which is called the posterior hypothalamus, for reasons I can explain if you ask me the questions, then this is returned to normal. And we have used in this case an electrode that we have just indwelled in the 3rd ventricle. It's quite easy to do, on the floor of the 3rd ventricle, and then you are close to the nuclei without having the risk of going through all the parenchyma. Epilepsy, actually we should say epilepsies. There are very different, various kinds of epilepsy. They all act differently. The benefits are not so good, but the indications are for patients who are not resectable and pharmacoresistant. Pharmacoresistant means that you have tried everything and still they have seizures. And non-resectable, meaning that most of the time the epilepsy is due to a focus. Most of the time you can resect, and this is the best treatment for epilepsy, and you get what is called seizure-free. 5 minutes, okay, that's nice. It's logarithmic. I like it. Okay, and so here a patient operated. She was 5 years old. She had 300 seizures per month, which is 10 per day. We were each followed by a deficit, so she was paralytic most of the time, and now she has been stimulated in STN 15 years ago, and she doesn't have seizures but a twitch of the thumb sometimes. So this is not as good as I showed you everything, but this is what we have as a last chance in patients who have no other possibility. Then, because of that, we tried back to psychosurgery, which was forbidden since the 70s due to mispractice. And this is here Freeman, who was Freeman and Watts were a psychiatrist and a neurosurgeon. The neurosurgeon said, "That's enough, I quit." And the psychiatrist continued, and he was going to do lobotomies using an ice pick and a hammer. And he had a mobile home. He would go from farm to farm to farm, and then lobotomized a lot of people who probably were doing exactly the same thing as before. But anyway, So Lars Lexell, who is one of the godfathers of functional neurosurgery, said a fool with a tool is still a fool. So it's not having good techniques. It depends essentially how you use it. So when we started the DBS, it became evident that we could restart psychosurgery, but also malpractice could be here. So we went to the ethical national committees, and all over the world there was a consensus that we could start it again, but under strict control. If not, then this would be forbidden again. So I show you here a patient who has obsessive compulsive disorder and cannot understand the idea of death. So but at that point, he moved his house because urgence.
Même si c'est moi qui l'ai dit, ça vous stresse.
So he cannot, then he goes into obsessions and compulsion. He had to leak something. If it doesn't work here, it will go on the floor. After 2 minutes of stimulation of the STN, you've heard STN already for Parkinson, for dystonia.
A priori ça va, mais je ne sais pas si c'est un effet psychologique, parce que il fait semblant, puis il dit tiens, je suis branché.
He didn't change his mood. He just
Ne réfléchissez pas, est-ce que vous allez le dire ou non?
That's a very important.
Non, le serpent il est mort, il est décédé, il est enterré au cimetière, il a une crise cardiaque.
We also, our colleagues in Toronto have, based on the observation of PET scan, showing that there is a hyperactivity when you have a very big, if you are depressed, then if you put an electrode here and stimulate at high frequency this part of the brain, then I don't show you the curve, but the patient are relieved from their depression. If you stop the stimulation, they go back to depression. So this one, very quickly, just because it is spectacular, that's a friend of mine, Brazil. That's a tic de la Tourette disease. And it is interesting because it's a mixture of movement. You see the tic, he has jerks, etc. And also mental disorder. He's yelling, saying bad words, and they go up to harming themselves. They can manipulate their elbow from the socket, cut their hands,
etc. O que os chiques fizeram na sua vida, sobre todos os aspectos, por exemplo, na escola?
But if you put an electrode in some place, and actually there are several places for Tourette syndrome, if you stimulate, this is what you have. They don't always look like this after surgery, but at least he's not having jerks nor yelling, and he has recovered a normal behavior. So
pode parar,
it is
pode voltar.
That one place can have an effect on mental and movement disorders. So anorexia mentosa also is improved by stimulation of the same area than for depression, which induces an increase of body mass index. And those patients, you know, they can die from starvation. You can't do anything. And then this is recovered. And in IAB, we worked quite well on obesity. Napoleon Torres did that in monkeys, and Stéphane Chabardes did that in rat. And recently in Clinatec, we operated the first case by indwelling an electrode through the same way I showed you for the cluster headache. You put the electrode in the third ventricle. On both walls of the third ventricle, you have the ventromedial hypothalamus, which is regulating some part of eating behavior. And this patient had 185 kilograms, and she lost, as you can see, 30 kilograms in 6 months, and just by not having this compulsion to eat. And then a big question is about ethics. We can go everywhere, we can do everything. Are we entitled to do that? There is a beautiful paper in Science where it has been shown that post-traumatic coma, when they wake up, if they were smokers before, some of them are not anymore smokers and for long. So they did a study, and they showed that there was a lesion in all those cases in the insula, part of the brain. It is easy to put an electrode in the insula. We do that every week because this is a place to investigate epilepsy patients, and it would be easy to stimulate and then get rid of this addiction to smoke. Is that possible? Is that necessary? Is that acceptable? That's a discussion, I leave it to you. But we remember that smoking may induce cancer, and cancer may induce death. Another situation, that's the patient we saw stumbling and having stimulation of the pedunculopontine nucleus to improve his. What we saw was that if you use different frequencies to be short, we may, as you can see here, at high frequency, induce a non-REM sleep. My wife says, well, what's the problem? It looks exactly like you sometimes. But then, on the contrary, if you stimulate at low frequency, which is what is needed, then you have alertness, and the patient, when the stimulator gets on, if you have set it at 5 a.m., at 5 a.m. they wake up and they say what happened. So could it be a solution for sleep disorders? I'm not saying that, I leave it to you. That's a real ethical problem. This here to say that even in big journal like Brain, you may see stupid things written by a neurologist. Okay, that's not a neurosurgeon, that's just a neurologist, an Italian neurologist in addition. But he says basically, now we have my best friends were a national neurologist in Milano, where I worked with them. He says, now we know a little bit about the brain, now we know a little bit about stimulation, now we can go to, we know that there is a moral brain, and now we could probably treat abnormal moral behavior. This is exactly what I feared to hear or read one day, because this is what could lead us again to a moratorium and suppression. What did we learn? We learned that what you have seen already, that there are different places where we can treat different diseases. But for instance, STN, we can treat Parkinson, we can dystonia, we can treat epilepsy, we can treat obsessive compulsive disorder. And when you record during the surgery in those different places, you see that globally the dysfunction in terms of micro-recording, of course, looks like the same, which leads me to put a very disturbing hypothesis, which is, if you look at the brain when it works, it looks like random activity, EEG is like random, etc., etc. You know that there are many, many, many things you showed us which happen in the cells, and this is probably why the brain is interesting. But when it dysfunctions, it has globally only one way to dysfunction, which is that the firing is not random anymore. It becomes bursting, like this. Worst is when you have tremor, then it is synchronous to that, and there is a higher rate. So globally, you have a very complex system, like society. And when you take the society walking like this, or even like this, then it becomes very identical, and this is the only way the brain has to get wrong, and other situations also. Now, very quickly, the mechanism, it's a very short slide because we don't know how it works. There is a lot of event working all together. This is what I put in this kind of equation, and this is another problem by itself. Then we have to realize, if you give me 3 minutes.
Yes.
Thank you. If not, I can stop. That's the best. It comes to light. So DBS has demonstrated symptomatic efficiency, which is contemporary to stimulation. Just it doesn't last. You stimulate, it works. You don't stimulate, it doesn't work, which is good, particularly when it comes with neurosurgeon. The degenerative process in the meantime has continued, has not changed, and when you stop stimulation, the Parkinson's disease is older than it was before. It has continued to progress. And there is no current therapies to show any curative potential. And then neuroprotection is a holy grail. Then, can we do it? Yes, I think we can try at least. Let's try. There are two options. One, I won't talk about it, which is using the high-frequency stimulation, which is inhibiting some kind of toxicity, glutamate toxicity. I don't talk about it. And to finish, we have been interested in Clinatec to the direct approach, which is to use a metabolic effect of near-infrared photomodulation. It has been known for years that light has good properties. Most of the time it was junk literature. Now it's becoming a very serious literature, and it's known that, for instance, near-infrared, interesting because that's one of the only wavelengths which goes through some millimeters or even centimeters of tissue, while the rest is usually stopped at the level of the skin. It activates photoacceptors, which happen to be cytochrome C oxidase, and this reboosts the electron transport chain and improve the mitochondrial function and ATP synthesis. And you know that Parkinson is considered as a mitochondrial disease. So what we did with our colleagues in Sydney, and the first idea came from a postdoc at Sydney University working with John Mitrofanis. We took mice and we give them MPTP, which is a toxin, and then this creates a Parkinsonian-like syndrome, if you can say that, in a mouse. So you see normal mice, okay, they run, they explore. MPTP mice, they are akinetic, they really move very little. And those who have received MPTP and light, they are not as active than the normal ones, but they are much more active. And if you look at their dopaminergic cells in substantia nigra compacta, it's close to normal, so we have protected them. Then we went to rats, and then we went to monkeys, and then we had to go to human in perspective. So we set up a system which would be used in monkeys and in human, and you see that we have operated monkeys, then we have implanted this system, and this system is hooked on a battery, like for stimulators. There is a laser source, which is here, connected to a fiber which goes into the brain and down to the level in between the two substantia nigra, and when we turn on the light, we have light diffusing. And as it diffuses, it goes to the left and the right substantia nigra compacta, so it's just with one surgery, easy surgery. And particularly, we expect it to be easy in human. So if we see briefly what happens in terms of behavior, this is a scale of disability. We give MPTP to those monkeys, and this is how they become, at that level they don't move, you have to feed them, you have to give them medication. And if you have given them using the system I showed you, a near-infrared light, then they keep being almost normal. This paper is just accepted amongst neurology. And then we are working now on the next step, which is for 2016, to use a system which is exactly similar, except it will fulfill all the regulations. The electrode will be indwelled in the third ventricle the same way I showed you for cluster headache or for obesity. And then when it is here, we can light on the system and expect for a neuroprotective. Curative, could it be curative? We don't know. We'll see what happens. And then we envision to have 5 patients starting end of next year. I like to say that there is no better future for a method than to be replaced by a better one, because this is for the benefit of the patient. When you happen to have invented the first one and to probably invent the second one, which is going to wipe off the first one, that's even better. And I thank you for your attention. This is Clinatec. There are about 100 now. This is a group who worked with NIA. This is John Mitrofanis from Sydney. This is a laser engineer. This is people from the hospital. And this is Clinatec, which I invite you to visit whenever you want. That's just far away. It's on the other side of the city, along the river. Thank you.